Are you a healthcare professional looking for a trusted concussion resource? Then you've come to the right place. From her New York City studios, welcome to Concussion Corner with your host, Dr. Jessica Schwartz.
Hello and welcome to the Concussion Corner Podcast. My name is Dr. Jessica Schwartz, and I'm so glad that you're here. Today, we're interviewing Dr. José Posas. What is sport neurology, that you ask? Today is going to answer those questions for you. I sat down with Dr. Posas, associate professor and sports neurologist at the University of Virginia, to unpack the evolving role of neurology in concussion recovery, from tackling systemic health disparities to advocating for underserved student athletes and students. Dr. Posas shares powerful stories of clinical impact and human connection. If you're a clinician, educator, or concussion champion, this conversation will challenge how you think about the interdisciplinary care, post-traumatic headache, and validating the patient journey, especially when the system falls short. Let's talk about building bridges, not silos, in concussion care. And again, welcome to our Teach One, Serve Many community. Let's begin. Dr. Posas, welcome to the Concussion Corner Podcast. It's so good to have you.
Thank you for having me. Really appreciate you.
I'm so stoked. Dr. Bert Vargas introduced us, and it's been the best thing ever. So just shout out to Dr. Vargas and, all of his connections. But let's get it started. I'm so fortunate to have you on our faculty for Concussion Corner Academy for our Part 2, Concussion, the Patient Rehabilitation Journey Part 2. It's been an absolute pleasure to learn from you. Our students are in love with you. They were so stoked. They were like, if this is how we're kicking it off, we're so excited. So just so you know, we'll get all those reviews and everything over to you shortly. So let's just kick it off with a softball. This is the first time the people at Concussion Corner are on the podcast side of things. Again, we're in over 60 countries, hundreds of thousands of downloads. And we're so excited to kind of expose it to the world and for people to get to know what sport neurology is. True story, our first podcast guest on the show was Jeff Kutcher. So We're full circling it right back to you. So I would love for you to let people know who you are and really how you ended up at University of Virginia and, really what is sports neurology and why is that important to you? Take it away.
Yeah. Thank you. I'm José Posas. I'm a sports neurologist by training. I'm an associate professor here at the University of Virginia. I've been here now for about a year, but I've been in practice for more than a decade. I will say what brought me to UVA, there was a need and a place. Think about Ferris Bueller's Day Off, right? It's like you got the Ferrari in the back, and it's like Ferris is trying to drive the Ferrari to downtown Chicago. They have an incredible multidisciplinary, multi-million-dollar, beautiful campus for sports medicine. And they had no one using their SOT machine, no one using the skilled athletic trainers, no one utilizing the physical therapist until I showed up. And I sort of was like, oh my gosh, I'm a kid in a candy shop. This is incredible. How can I partner with our neuropsychologists, with our physical therapists, with our occupational therapists, with our speech therapists, with the PM&R sports medicine doctors, with the orthopedic sports medicine doctors? Like, what a dream. So it's been incredible. It's been wonderful. I still pinch myself, and I'm so happy to be here.
Oh, fantastic. Sports neurology is such a unique niche, and I would love for you just to highlight what is sports neurology and why did you go into it? Neurology in itself is a niche, and then sports neurology on top of that is a niche within a niche. And I'd love for people to know, hey, how can we find a sports neurologist to refer to? And then why is this so integral and important for concussion care, especially with 94% of concussion patients having headache or migraine post-concussion?
Yeah, that's a great question. So I'll say that sports neurology itself, you're right, it is a niche within a niche. I think in terms of trying to figure out who to refer people to within neurology, we are in the age of web ads and searchables and LinkedIn and all this other stuff. People who do sports neurology training or are interested in sports neurology will typically tag themselves. We tend to self-select. We are a group of people that not only treat athletes who become injured, particularly with concussion, but I think within sports neurology as well, there's an even smaller niche of people like myself who are big nerds about peripheral nervous system injury. So think about your throwers, your fencers, your pitchers, people who pinch brachial plexus nerves and stuff like that. I get really geeked out about that. I know Dr. Brian Hanline gets very interested in this kind of stuff. My mentor, Dr. Vernon Williams, also very interested in peripheral nervous injury and ultrasound-guided injections to try to help folks get back to function. We don't just help people who are injured get back to function. We think about special populations, people who have long-term lingering neurologic issues or injuries, right? One of the most, I think, heartening patients that I learned a lot from was a Special Olympics athlete. He had intellectual disability, but this guy was just an incredible athlete, and he had an an incredible spirit. And, I helped him, but he helped me really kind of learn to be more compassionate and understand how to meet not only a patient, but an elite level athlete who has special issues that I had to pay attention to that was outside of my comfort zone. So that was really a great growth moment for me. In addition, I think throughout the lifetime, we think more and more about brain health. How do we get the people who would previously be defined as couch potatoes invested in their own health and really work on the cerebrovascular, the cardiovascular systems that support the brain, and make sure we don't just sort of live from injury to injury, but really live well.
Fantastic. And it's so great to kind of connect with all my neuro nerds. Even my cycling team is Team BDNF. Brain-derived neurotrophic factor, just because we want to get that low-load cardiovascular activity, even after my own injury, my brain injury in 2013. And then I, was unfortunately hit by a tree branch in 2022 in the head on our first vacation post-COVID. And again, just really like connecting to the importance of that interdisciplinary model, those interdisciplinary conversations, and reaching across the aisle. So stoked to hear all of the above, and also for the patients that have been fortunate to be served by you as well. Now, you've held multiple leadership roles, from being on the AAN, American Academy of Neurology Board of Directors, to your work on the neuro panels. Can you share some behind the scenes look at like what a project that is especially meaning to you that may be in the past or maybe coming up?
Yeah, I think the big thing on my horizon here at UVA, we've secured grant funding for something called the Jefferson Cares Project. So the idea is that we will be elevating the care that we give any undergraduate student here at UVA or graduate student. So and I know from interacting with athletes at various collegiate levels and high school levels, there's a certain amount of, like, for lack of a better word, favoritism, right? If you're on the football team, you're going to get an excellent level of care. You're going to get great meals. You might get a scholarship, especially if you're recruited. Why not for the rest of the student body, right? So I sort of think in my own head, whether you're an athlete or a mathlete, I, as a neurologist, as a sports neurologist, if you are concussed, I want to give you the best level of care I can. I don't want to give lesser level of care. So the Jefferson Cares Project, funded through the Jefferson Trust, is that community project which will really be able to elevate the care that we give to any undergraduate student or graduate student here. It doesn't matter if you're the star quarterback or you are someone who's in the drama department or doing your dissertation on esoteric religious studies and perceptual studies. My gosh, we need to get you back to where you need to be for that field that you're interested in.
Yeah, and it's so important for all of these special topics and subspecialties. Even before I got into concussion, I was the program director of a prosthetics education program for civilians, actually, because I found that our vets, actually, which are often not as well cared for, but with prosthetics are phenomenally cared for and provided for, that the civilians actually had the opposite, and they really didn't know what to do or how to move post amputations. It's wonderful to see kind of that full 360 coming back to serve the community. Now, I'm just thinking in terms of, you're an associate program director now at the University of Virginia. How are you training the next generation to show up better for concussion patients? Again, we know that 2015 was that first formal didactic year that neurologists had training in concussion and traumatic brain injury. Our brain physicians and colleagues, and your colleagues and who you are, how are you training that next generation to show up? And even a flip of that question to pivot, how are you having communication with those that may be practicing 20, 30, 40 years out, so that we're really meeting the concussion patients where they are from a rehabilitative standpoint?
Excellent point. Very astute topic here. I think the big thing that both is the junior learners and the more senior learners, the way that I sort of tie the thread together for both of them is that we need to move away, and you and I have had discussions about this, other folks who are in the field and in the know have had discussions about this. We need to move away from the misnomer of post-concussion syndrome. Right? You can't cure a syndrome. It's something I just suffer with. We need to think about persisting symptoms after concussion, right? And it's not just sort of a word salad, word soup. This is not Chilean sea bass versus Argentine toothfish. It's not exactly the same thing. We have to shift conceptually of what we're doing. We have to think about, oh, well, he's just out of concussion and he's just never going to get better. No, he or she has a convergence insufficiency, vestibulopathy, whiplash, cervical facet arthropathy. They have a circadian rhythm disorder. They've got adjustment disorder because it's now been 6 months and, they're having difficulty getting back to their life and they're anxious about their work and their employment. I mean, we have to think about the patient holistically. We have to really circle not only the specialists around the patients, including the folks I've mentioned before, but also circle our thought and really identify, like, where is this patient not able to function the way they were before their injury, and how do we get them there? It may not always be like me prescribing a pill or doing an injection, but sometimes it is that very human, like, connection. Like, how do I sit and talk to them in a way that they feel seen and heard?
That's fantastic. And, the number one thing, not only as a brain injury survivor myself, but also as a physical therapist, how are we really connecting with our patients? When people see me in New York, they see on average between 6 and 7 providers before they see me because they've been essentially mismanaged up until the point of when they arrived to my door. Just thinking full circle here, we need to make sure that we're validating the patient symptom profile. And that's kind of where I've kind of that's my full mantra wherever I go, whether I'm speaking overseas or on the podcast or in the States, how do we validate the patient symptom profile? And we're doing that by doing targeted physical examinations, which are lined up. So we're basically able to find those objective measures, whether it be somatic, cognitive, physiologic, sleep, any other mental health premorbid conditions and things like that. We need to identify all those because pain is real. You can't scan pain, maybe a little bit with some fMRI stuff, but again, that's not standard for practice. It's more research wise. So it's just so lovely to hear a neurologist, a sports neurologist connect to not only, we can prescribe medication for migraine and traumatic headache and so on and so forth. And we'll talk about that. But really being able to connect to hey, we can serve these folks, and concussion is a rehabilitative injury, and reaching across the aisle. Who have you kind of been most surprised with from reaching across the aisle outside of neurology and sports neurology from a rehabilitative lens in terms of you reciprocally learning and vice versa, from your learning journey as a neurologist?
Yeah, I think early on, I was completely ignorant of how huge having a competent and accessible vestibular rehab specialist was. That was one of the very first lessons I learned in fellowship, and my God, I hold it near and dear, sacred to my heart, right? I literally will meet with our vestibular rehab team, including the oculomotor occupational therapist and the cognitive rehab speech therapist that are outside of the confines of my institution. I will work in the community. I'll work with them for our more difficult patients. And that communication of me taking time out of my day, meeting with these team of physical therapy, occupational therapy, and speech therapy and saying, how can we as a team serve the patient better? That's been tremendous. And I think, again, that gets back to the central theme of, I'm not an island. I don't have hubris about this. I don't have ego about this. I need help. We need a team. This is a team sport. No matter how dope Jaden Daniels is, no matter how dope Joe Burrow is, it doesn't matter. They need a team. So we need a team of people to help us achieve the goal of getting these people back to themselves, really.
Fantastic. I mentioned Vernon Williams, and I can't help but connect. I met Dr. Williams in 2016 in Long Beach when we were doing the state conference for the California Physical Therapy Association. And I've been following his career ever since. And he does such wonderful conversations on DEI and structural inequities in concussion, in neurology, just inpatient care in general. How do you see structural inequities like social determinants of health affecting how concussion care is delivered or accessed for concussion patients?
Oh my gosh, what a deep and thought-provoking question. So I'm going to start by saying, I'm going to go the macro, right? So we're going to go big names, big people that everybody knows. Tua Tagovailoa. Everyone who pays attention to football knows his sort of journey with concussions and the fact that he sort of said, I'm good. I learned from Dr. Williams early on when I was in fellowship that there is a certain selection based on race, socioeconomic status, ethnicity, however you want to slice the demographic of kids who have been taught either by TV or by their environments that they're not going to make it into adulthood and be successful. Therefore, there are some kids who come from certain backgrounds, again, race, ethnicity, socioeconomic status, gender, etc., whatever. There's a slice of people who, if you told them you can make millions of dollars in your lifetime, you can set up your parents, you can set up your siblings, you can set up your kids, but you will be demented by age 40, there's a good chunk of them that'll say, let's go. I'm into it, right? And I'm not just talking about kids of color, global majority, however you want to talk about them. There are kids in rural parts of Appalachia that I'm finding out here in Virginia that would take the same exact deal and say, I will sacrifice myself so I can take care of my family, take care of my community, take care of my loved ones. So that's a commonality, but it's a very important one to think about in terms of how do we as a healthcare team reduce harm and reduce them from going into something that will really hurt them and set them back.
Now, a word from our sponsor. Did you know that sport helmets are rated on a 5-star system similar to cars? And the safest helmets have nothing to do with price, brand, or availability? Since 2011, Virginia Tech researchers have been providing unbiased helmet ratings that allow consumers to make informed decisions when purchasing helmets. The helmet ratings are the culmination of over a decade of research identifying which helmets best reduce concussion risk. This work is done as part of Virginia Tech's service mission and is 100% independent of any funding or influence from helmet manufacturers. Our mission at Concussion Corner is to expose you, the listener, to trusted spaces in the concussion arena that translate to clinic next day. Please visit the Virginia Tech Helmet Lab website in our show notes or at bit.ly/Virginia Tech Helmets and spread the word to aid in lowering concussion risk in your community. Thank you for tuning in, and let's begin the show.
So interesting. In 2013, I was hit by a car, rear-ended by an unlicensed driver here in New York. And, during my recovery, which was 14 months, it was a persistent recovery. I had a learning disability growing up as a kid, totally connecting to hey, this was most likely ocular motor in nature. And that's why I was skipping lines when I was reading and so on and so forth. I started the academy and I started the podcast, quite frankly, to be able to reach people all over the world to have these conversations. And I think at the end of the day, for me, it's an accessibility issue. It's no matter who I met on this recovery, whether it be professional soccer players, professional football players, everyone in between, the Medicaid patients in this country, in the United States, all the way up to, cash paying, professional athletes, the mismanagement of the concussion patient was so much more prevalent than the well cared for concussion patient universally. And that's why I started these conversations, to have, all over the world on the podcast, especially. And then we teach it in the academy. In terms of meaningful recovery for a persistent concussion patient that you can think of or connect to, are you able to connect or share, if you would, about a persistent post-concussive symptom patient that recovered and kind of what that journey was with your involvement as sports neurologist, and then maybe with other team members that kind of help bring that person through to get them back to life and society and function, really?
Yeah, there was... She was, when she was injured, motor vehicle accident, a 16-year-old woman who I was seeing who had terrible post-traumatic headaches, just awful. By the time she got to me, she'd even tried and failed. And it's off-label for pediatrics, or it was off-label for pediatrics, but Botox for migraine, which is a pretty powerful and very strong and well-documented, very effective post-traumatic headache or migraine headache treatment, but it wasn't touching her headaches. So I examined her, I pressed her on the back of her neck, she about jumped out of her skin, jumped off my exam table in pain, and she cried, and I'm like, oh my God, I'm so sorry, handed her the tissue box, and she said, in the year plus since my accident, no one's actually pressed on the back of my neck like that. And I think that speaks volumes to, this is a young Caucasian female from a lower socioeconomic part of the state of Louisiana, where I'm from, who was on Medicaid and just didn't get the right even physical exam, which is super disheartening. Anyway, when I first met her, she was in jeopardy of failing high school because she had missed so many days because of her headaches. Somebody who I worked with said, hey, thanks for trying with our family junkie, because she was also on a bunch of narcotics and benzodiazepines, things that can form habits and addictions unwillingly. But by the time I actually got my treatment with her and got her to the right rehab and did injections and managed medications, she's graduated nursing school and she's out helping people and helping folks recover and easing their pain and being the compassionate person who I know she is.
That's fantastic. And I think, we take this oath to do no harm, but again, we have to also be kind to ourselves with the Dunning-Kruger effect. And, you only know what you know, and you can't know what you don't know, and it's okay. And, we really want to be raising, Concussion Corner Academy graduates to really be comfortable with saying, you know what, I don't know, but let me take the time to find out. And then we expose them to all of you tremendous faculty at the top 1% of your game. And we want to make sure that we're serving our patients, 360, and what a wonderful story to have. And, it's so interesting because I know the APTA did a big push with opioids and pain medication, and actually zip code was the number one factor of how and why those were prescribed. And therefore, when people are in pain of color, they're not prescribed. And, we have to make sure we're doing our due diligence 360. I don't prescribe medication. You do. Any thoughts there as we wrap up this first episode?
Yeah, there's a great podcast, I believe it was through the New York Times, and the reporter looked at a mortality related to the opioid epidemic in West Virginia. And exactly what you told me, where we know that people of color receive less narcotic pain medication, was actually protective in terms of reducing opioid mortality. So, in that intersection of sort of structural bias and things that are beyond the individual healthcare provider, things that unfortunately we have all been taught in medical school and bad things that we learned a long time ago, the attempt to help can be harmful. And I think it's important, at least, and I'll say personally, I don't prescribe opioids or benzodiazepines or narcotics for any of my headache patients, I try to really think about what is the root cause analysis. And sometimes patients come in and at the end of the visit, they're like, oh my God, thank you so much. I was worried that you were going to be like the other doctor who just said, here's a new script, try a new thing, just throwing stuff at me without actually listening to me and explaining like, no, your neck is involved, or no, the suboccipital muscles are involved, or part of the reason that you're having headaches is because your eyes aren't seeing straight. So we need convergence insufficiency training, and we need to reduce your screen blue light filters and all sorts of other things. But again, a holistic view of the patient and validation of what they're suffering with.
Yeah, and I think that's just why that interdisciplinary conversation is so important. For me as a physio, again, if I'm having physical therapy conversations with a colleague in my own lane and aisle, they're like, you know what, Jess, I got like 80% there. I'm treating their neck, because that's what we do well. I'm treating their neck, but I just can't figure out why they're just still off. And they're usually missing something ocular motor or visual-vestibular or potential neuroendocrine, right?
That nasty dysautonomia, right?
Yes, that nasty dysautonomia.
We have to pay attention to that. That's a newer one that's new to me, and I'm still learning about that, admittedly.
Yes. And someone who lives with it, let me tell you, we can have that conversation, and we'll kind of plant that seed for episode 2 that we're going to have, the following week. But we're going to talk about dysautonomia. We're going to talk about sex and concussion, intimacy and concussion, and, why that physiological portion of concussion is so important to function and to our colleagues like yourself to prescribe and reach out and refer. At the end of the day, just thank you for doing what you do. And, the last question that I want to end with on this episode, and we'll have part 2 next week, is that for your colleagues in neurology, we have some that may not be exposed to concussion education, that haven't had, the reps. And it really is a rep thing. You really have to see 1,000 concussion patients to really kind of get it when you see it, because it's such a different presentation. It's the same but different at the same time. To your colleagues that may be, locked up with either, like no fault, they might be in a poor insurance situation where they're just kind of told what to do and they don't really have that flexibility to kind of shift. For those that may be prescribing or overprescribing medication for dizzy patients post-concussion, the migraine or post-concussion, what's your feedback to them at the end of the day of like, hey, this is a 360 injury, and how can they maybe shift to learn more and reach out to, to kind of broaden their education?
This goes back to the sort of relationship type of advice that people roll their eyes and groan about. But sometimes you really need to ask, like, what is it that you want out of this interaction? How can I help you? At the end of the day, healthcare is a service industry. So we need to ask, what do you want to return to? Do you want to be able to go back to your weightlifting record? Do you want to be able to go back to competitive cycling? Is it competitive cheer? Is it taekwondo? Do you want to actually not play football anymore and pursue acting? That was one of the patients I saw in fellowship. This kid was 14 years old, 6 foot tall, 200 pounds, and the kid just didn't want to play football because it hurts. He wanted to act because he was in Los Angeles. And, that was its own whole conversation, as you can imagine. But having a discussion with the individual who has suffered with the injury and not having a conversation with the injury, right? Let me say that again real quick. Talk to the person, not their injury.
Fantastic. Dr. Posas, thank you so much for coming on. We're going to be talking about all things sports, sex and concussion, intimacy, and headache and migraine part 2. For those that want to find you online, what's the best way for them to reach out to you and get social with you from a collegial standpoint?
I'm on Instagram. I have Blue Sky and Twitter, but it's hard to keep up. I try my best.
Yeah, I hear you. Well, thank you so much for coming on. And again, thank you so much for being a part of our Teach One, Serve Many community. It's been an absolute pleasure to learn from you and to get to know you over the past couple years.
Thank you. Pleasure's mine.
Take care. Okay, so that's a wrap on part 1 of our conversation with Dr. José Posas, sports neurologist, educator, passionate advocate for equity in concussion care. We're so happy that we had him on. We are incredibly grateful to have Dr. Posas as part of our world-class faculty here at the Concussion Corner Academy side of things. If you're ready to take your learning to the next level, you'll get the chance to learn directly from him this fall in our Concussion the Patient Rehabilitation Part 2 journey. Whether you're joining us live or on demand, you'll have the opportunity to engage with Dr. Posas and our full interdisciplinary faculty to deepen your clinical skills and better serve your patients internationally. Make sure to tune in next week for part 2, where we'll explore the intersections of concussion, dysautonomia, and intimacy in concussion, and why this conversation belongs in every clinic. As always, thank you for being a part of our Teach One, Serve Many community. We can't wait to see you next. Take care.
Thank you for listening to the Concussion Corner, hosted by Dr. Jessica Schwartz. The information in this podcast is for entertainment purposes only and not to be used as personal medical advice. Don't forget to follow us on social media on Facebook, Instagram, Twitter, and YouTube at Concussion Corner.